Good afternoon, everybody, and welcome to the FEMA Region 2 Puerto Rico Caribbean Area Office Individual and Community Preparedness Webinar Series. My name is Jose Marchan, and I am a Program Analyst and Preparedness and Continuity Specialist for Puerto Rico. Before we begin, I would like to test that you guys can hear the audio. So please type with a number 1 on the chat box that you see up in the screen. Excellent. I see number 1. Thank you very much. So before we begin, I would like to provide some logistics considerations. Today's proceedings are being recorded and captioned. The archived event will be available on the Region 2 website in the coming days. You should hear audio through your computer speakers, so please ensure that your volume is turned up so you may hear the proceedings accordingly. In the top right corner, we ask if you'd like to receive news updates from Region 2. If so, please enter your email address and we'll be sure to add you to the distribution list. Please do not put your email address in the chat box as it will not register and you will not be included in the distro list. We will have a question and answer session after the presentation concludes. You'll see a Q&A pod in the lower right-hand corner of your screen, so please feel free to submit your questions about the subject matter here, and time permitting, we'll do our best to answer them. Finally, all the PowerPoint presentation from today will be available for you to download in the file share pod at the end of the presentation as a PDF file. You can click on the file and download it using the download button. That said, on behalf of our team working to strengthen preparedness across New York, New Jersey, Puerto Rico, and the U.S. Virgin Islands, I am thrilled to welcome you to this special weekly series of preparedness and resiliency webinars in close coordination and collaboration with our HHS partners. As part of FEMA's 2018-2022 National Strategic Plan, our primary goal is to build a culture of preparedness. We offer workshops and seminars to enhance the preparedness of individuals, families, and small businesses, building resiliency in our communities. So I am pleased to welcome you to our webinar series, Centers for Medical and Medicaid Services, Special Caribbean Hurricane Preparedness During COVID-19 webinar series. That said, please welcome the HHS team for this webinar. In no particular order, we have with us today Marina Diaz. As a staff director for CMS Puerto Rico, Marina Diaz leads and coordinates local external engagement efforts with all regional stakeholders and customers in Puerto Rico and the U.S. Virgin Islands. Marina was appointed director of the CMS Field Office for Puerto Rico in June 2016. Prior to joining CMS, Marina's career had been devoted to designing, developing, and transforming healthcare delivery systems, including multi-specialty clinics, psychiatric hospitals, and managed mental health plans. A passionate believer in the possibility of recovery from mental health challenges, she has innovated opportunities for better health for individuals, families, and communities. Marina holds a bachelor's degree in psychology and a master's degree in health services administration from the University of Puerto Rico School of Public Health. She conducted a postmaster fellowship at the Elmhurst Hospital in New York. We also have today Denise Molloy. Ms. Molloy is the director of the New York Division of Innovation and Operations, which includes New York, New Jersey, Puerto Rico, and USVI. She has been in this position for 6 years and has been in federal government for over 20 years. Her division manages programs and inquiries related to fee-for-service operations, as well as innovation projects, provider enrollment, claims and coverage, and Freedom of Information Act requests. We also have with us today Lauren Reinerstedt. Ms. Reinerstedt is Director of the Northeastern Survey and Enforcement Division of the Survey and Operations Group of Center for Clinical Standards and Quality at CMS. The Northeast Division covers 30 states, the District of Columbia, Puerto Rico, and the U.S. Virgin Islands. She joined CMS in 2007 and has worked in the Center for Program Integrity and CCIIO's implementation of the ACA and Marketplace. Lauren has held management and executive positions in long-term care systems, including management of skilled nursing facilities, ambulatory care, and continuing care programs. She has managed an institutional review board, clinical research, marketing, public relations and grants, and corporate education in long-term care systems. She received an MA and a PhD in health studies from NYU and received an MPA from LIU. She's a licensed nursing home administrator and has taught at NYU, City University of New York, and local colleges. We also have Roxanne Rocky Rocco, manager of Northeastern Acute and Continuing Care Branch. Rocky started her career with CMS in September 2016 as either certification and enforcement branch manager in the CMS Philadelphia office. In November 2019, she became the manager of the newly created Acute and Continuing Care Branch. Rocky directs and manages serving, certification, and enforcement activities for non-long-term care providers and suppliers participating in the Medicare group. This includes ambulatory surgical center homes, health agencies, hospitals, including swing bed services, end-stage renal disease, ESRD, facilities, community mental health cares, and others. In addition, Rocky has experience performing service under various regulation sets and is well-versed in the conditions of participation for hospitals and the requirements under the Emergency Medical Treatment and Labor Act. And last but not least, we have Ivelisse Salz, who is a health insurance analyst in the Division of Medicaid and Children's Health Operations, DMCHO, in the New York Regional Office of the Centers for Medicare and Medicaid Services. Ivelisse Salz is a health insurance analyst in the division, and this office is responsible for federal oversight of the Medicaid and Children's Health Insurance Program in New York, New Jersey, Puerto Rico, and the United States Virgin Islands. She has 19 years experience in healthcare. Ivelisse obtained a bachelor's degree in business administration and a minor in communication from Herbert Lim College of the City University of New York. Please help me in welcoming Marina, Denise, Lauren, Rocky, and Ivelisse, our HHS team for today's webinar. Pleasure having you here today, and the floor is yours. Thank you very much.
Thank you so much, Jose, and I'm proud to join your agency in this unified effort for a culture of preparedness. It seems that nature has wanted this side of the world to be very prepared because we have experienced quite a lot of events, but it has made us stronger. So thank you so much for this effort. Thomas, we can go to the next slide, where I'm going to be talking to you about what do we do in terms of CMS, Puerto Rico, and the Virgin Islands during emergencies. I'm going to mention some of the nuances that make our efforts of preparedness and response a little bit different, the objectives of CMS during COVID-19 response. I'm going to also cover some information on how our component of drug and health plan management collaborate during these disasters. And I brought a little bit of lessons learned. They were a lot, but I brought the ones that I think has made a difference in our future preparations. Next slide. Okay, CMS role during disasters is to make sure that all of our beneficiaries are able to continue receiving care, and also those that provide those services are paid appropriately. We also support the economic stability of the system of care because we learned that economic stability makes a difference for our beneficiaries on whether they will maintain their presence in Puerto Rico and the Virgin Islands or they will decide to leave. Next slide. There are a couple of nuances I want to mention. In the USVI, both of our hospitals are owned by government. Many beneficiaries receive treatment off their island, not only during their disaster, but even before, under normal circumstances, because of maybe they don't have the specialty or the procedure is not conducted in the island, or they prefer to go close to family members. And in Puerto Rico, the totality of our Medicaid program is managed by health plans. I know Ivelisse will be expanding on this. And 79% of our Medicare beneficiaries opt in a Medicare Advantage plan. And most of our hospitals are privately owned. Next slide. The nuances I just mentioned may have some impact on the way that CMS can directly provide for these providers. For example, in the case of accelerated or advanced payments, because our providers of Medicare are mostly billing Medicare Advantage companies, in our formula, in CMS formula, we do not recognize those payments or that reimbursement in order for them to be able to get the total amount of revenues they get from Medicare. We also face some issues with transportation due to the fact that most of the non-emergent transportation is also provided by private companies. And some of our institutions, hospitals, because they're private, they may not be able to receive immediate federal assistance from some programs that require the provider to be a nonprofit or government-owned. Because of poverty, resiliency takes more time. There are still some communities that are facing issues that have not recovered from Maria or Irma. And many of our beneficiaries relocate to other jurisdictions for long periods of time. The main contributor for this is the system of care. We found out that when people cannot get their care, they go to wherever it's available. Next slide. So what does local engagement and administration, the component we work for in Puerto Rico, do? We provide information on the applicability of waivers for USDI and Puerto Rico stakeholders. We provide daily reports to the management of CMS on the issues of particular impact in our beneficiaries. We meet regularly with all stakeholders and reach them with the appropriate CMS components. Most of our work during and after a disaster is to make sure that our role as boots on the ground becomes an information and awareness, situational awareness information. So it's distributed to all the components and they then use it for their purposes of helping in a unified way for the resilience and response. Next slide. Our drug and health plans component makes sure, as I mentioned to you, almost 80% of our beneficiaries opt in a Medicare Advantage in order to get their Medicare program. So our drug and health plans program management acts as a monitor to ensure that CMS goals are met through them and that they produce letters that explain how the waivers and flexibilities that you're going to be learning more when my colleagues discuss them, that these waivers and flexibilities are also impacting our beneficiaries that have a Medicare Advantage. That component also receives claims and complaints from beneficiaries and providers and resolves them. And they have account managers discussing with their health plans about how these plans are managing our beneficiaries for the different locations. Next slide. I need to call your attention that number one should say increased testing, not, actually it does say it. I'm sorry, I saw a typo before. The COVID-19 goals for CMS can be organized in 5 main areas. One is to increase testing access to testing and availability of testing. Hospital Without Walls, which is the ability for hospitals to designate areas to treat patients with COVID, and also while maintaining the other patients being treated. The expansion of workforce, the reduction of paperwork or burden, and the expansion of telemedicine. Next slide. Thank you. In our Hospital Without Walls effort, allows hospitals to bill for services rendered off campus in order to control the spread. Some hospitals needed to put alternate sites. Some other hospitals needed to move some departments or use other levels of care, like a skilled nursing facility, in order to house acute patients. That all those flexibilities were put together so that hospitals could have a better position in dealing with the surge of cases that they may have because of COVID. All these alternatives, and by the way, this is not an all-inclusive list. I will provide you resources where you can see the whole list of what does it mean in our effort to have Hospital Without Walls, how CMS created an environment of permitting hospitals to continue working with COVID-19 patients, but also being able to maintain some economic stability because they recognize some departments and some efforts. Next slide. In the expansion of workforce, a reduction of burden was asked for our intermediaries that credential physicians to make those processes leaner so that we could register more Medicare participants in the Medicare network. Again, there's more information, and I will provide you some links where you can get more information on how every flexibility or waiver impacts all of our ecosystem of healthcare. Next slide. In the access to testing, tests could be ordered according to the territory's law. Tests could be ordered by other professionals, not only by physicians. In Puerto Rico and the Virgin Islands, I saw that pharmacies were able to order, and that made at the height of our response, that made a big difference for people to get their tests. Health plans were asked to cover for testing without cost sharing to the beneficiary. I have to say that in the beginning, laboratories were not very comfortable with the fee. However, CMS moved quickly and adapted the fee in order for hospitals and laboratories to maintain economic stability while doing this testing. That made a big difference. Next slide. Telehealth, if you ask me, is for me the flexibility and the way that CMS adapted to this virtual reality made a tipping point for the delivery of healthcare through virtual environments. I have to say that before COVID, in both in Puerto Rico and the Virgin Islands, the amount of telehealth encounters was very scarce. There were many barriers. One of them was eliminated by the flexibility. As you may all know, telehealth is the interchange of information between a patient and his or her provider in an effort to enhance the health status of the patient. Video and voice, at the beginning, only video and voice interchange was allowed. However, since March, it was recognized that some of our beneficiaries do not have access to technology that can supply video and voice for treatment. So the only voice was allowed as a telehealth encounter. The other aspect that created an environment for telehealth to grow was that the reimbursement to that provider would be the same as a regular visit. Next slide. Also, the providers that could do telehealth was expanded from only, especially the law in Puerto Rico and the Virgin Islands, only allowed for physicians and psychologists to conduct telehealth. Now we see this spectrum of providers that can do telehealth, and that there is a code for them to bill for those services. It's important to mention that these professionals need to be certified as CMS providers in order to provide telehealth and bill for those services to our beneficiaries. Next slide. There was also the reason that these flexibilities have been able to adapt so quickly to the situation is that CMS put together a help desk mailbox that is able to receive recommendations and questions from providers and other stakeholders on the effect of waivers and flexibilities in their own reality. I saw how the next round of flexibilities, the one that came in by the mid-March to the end of March, considered feedback like the one I mentioned to you on the use of only audio for telehealth. That came as a reaction of CMS to recommendations and reactions from stakeholders. And that's what we, exactly what we do in local engagement. We meet not only with those local and federal agencies that are dealing with the disaster or the event, but we also meet with the people that are receiving care and offering care. Next slide. What did we learn? This is not exhaustive. There are many, many lessons, but I wanted to provide you with a summary of those lessons that have defined how we deal with the next disasters. The first one is that chronic conditions become extremely lethal when continuity of care is not available. We have established many preventive actions in order to identify where are our most vulnerable patients. In the first Maria and Irma events, we lost people not directly related to the winds or to structural damage, but because they had chronic conditions that were exacerbated, and the lack of electricity and other support activities did not help them stay alive. The consistent care management is crucial. Any agency, and we have talked with other agencies like NDMS and other agencies that provide care management, we have been able to talk to them on how crucial it is for those beneficiaries to be connected to the system of care. Also, when we talk about suspending elective procedures, we should also examine for how long. We are seeing now with this disaster, with the COVID disaster, that people didn't want to go to the system of care. They did not want to go to hospitals. They interrupted their care, and because they were waiting for an elective procedure. But sometimes how elective it is for you not to have surgery for a heart condition or for cancer. I think the next time, and I have voiced this with other forums here in Puerto Rico and the Virgin Islands, we should be very careful about how to time the suspension of elective procedures. Also, we learned that those hospitals that follow the emergency preparedness regulations, the ones that probably Lauren will be talking about, those hospitals that follow that, especially defining their community and participating in coalitions, have definitely made it easier for their communities to be resilient. We've seen it. We have compared hospitals that were able to come back sooner, and the common denominator is that they have an emergency preparedness plan that was carefully designed but also practiced. And the last lesson, I think I already mentioned to you, that the telehealth expansion created a new space for treatment. I don't think it will ever substitute the person-to-person experience, but definitely it does help people with immune situations, not only because of COVID, but also for other conditions that affect your immune system. Next slide. Here I am providing you some of the resources that we usually visit very, very often to get more clarity on the things that I just mentioned to you. And with that, I'm gonna pass it to the next person, and I'll stay here for questions.
Thank you, Marina. This is Denise Malloy. I'm the director for the New York Division of Innovation and Operations. And what that means is that I help to manage and troubleshoot issues related to traditional Medicare, Parts A and Part B. That is inpatient hospital insurance and also doctor outpatient insurance. That would be Part B. So I would like to go over some of the waivers and flexibilities that have been available, and so that's what we'll discuss over the next few minutes. Next slide. Okay, so 1135 waivers, that's what they are called, and as you know, Medicare institutes policy and procedures. So we're a regulatory agency. We make rules for safety, for healthcare. We are also an healthcare insurance company, right? We pay for healthcare services. So there are a couple of ways. Obviously, we do a lot of other things, but for our purposes, that's what we're focusing on. So there are a couple of ways that waivers can be used to help in an emergency. The Secretary of the Department of Health and Human Services uses the section of 1135 of the Social Security Act to modify certain Medicare rules and regulations. Next slide. The time frame. Many people have asked how long the waivers are for. The waivers are for the duration of the emergency. So when the emergency is over, the waiver is suspended. I have received questions, how long will the waiver be in place? I wish I knew how long COVID was going to last. Unfortunately, no one seems to know that at this time. So how long the emergency will be in place, depending on what it is, we don't know. We know after Hurricanes Maria and Irma, the hurricane only lasted for a few days, but the emergency in certain parts of the island lasted for a year. There's still areas that are recovering and being affected by hurricanes that were so long ago. To some people, it was like it was yesterday. So depending on how long the emergency is declared for, that's how long the waivers will last. Next slide, please. Okay, blanket waivers. Blanket waivers mean that you as a provider do not have to apply for the waiver. The waiver, when it's a blanket waiver, is instituted for the whole area affected by the emergency. For COVID-19, there are national waivers. For hurricanes, they were waivers that were specific to Puerto Rico and the USVI. We are allowed to issue blanket waivers depending on what the emergency is. When the waiver is issued, no one needs to apply for that. When there's an emergency, we can also provide health care providers other flexibilities to make sure that Americans continue to have access to the care that they need. Next slide, please. What waivers don't do. This is important because sometimes people think there's a waiver, we can, do whatever we want, that makes sense, and that's not always the case. Waivers do not offer grants or financial assistance. So when we're talking about 1135 Medicare waivers, it's not to give out grants or financial assistance. Other acts might provide that, like the CARES Act, and other government agencies and acts might provide for that. But when we're talking about Medicare, that is not part of what the waiver does. The waiver also does not allow someone to be paid for services that are not usually covered, or to cover people who are not otherwise eligible for Medicare. So basic eye care is not going to be part of the waiver because by statute or by law, Medicare cannot provide those services. Hearing aids are not going to be part of the waiver because by law, we don't provide those services. So a waiver is not going to waive that. You also should not base your decisions on evacuations on whether there are waivers or not. Those are local issues, and you would have to listen to your local authorities as to whether you should evacuate, if there's a hurricane, if there's a flood, depending on what it is. That's something that is not addressed by the waiver. Once the waivers are approved, you will always be reimbursed accurately, and you should keep records so that you can make sure that you are able to be reimbursed accurately. Next slide, please. The current waiver. I don't know if, I'm not sure if the link will actually work on the PowerPoint slide, but you can certainly copy and paste it into your web browser, and this will give you the link to the current blanket waiver, and that will provide a lot of information as to the types of things that are able to be waived. It's certainly what is available right now. Next slide, please. Okay, I know this is hard to see and hard to read, but there are examples of some of the flexibilities we've been able to supply, and I can't give you an exhaustive list, but what is most important to understand is that the waivers and the flexibilities will depend on the emergency. So certain things might not apply in a particular emergency, but some of the most common issues that we have for home health agencies, we have certain waivers that apply to that. One of the very common waivers is waivers of the 3-day hospitalization rule or the 2 midnight rule, so that a beneficiary does not have to be admitted for 3 days in the hospital before they can go to a skilled nursing facility. That's a common waiver that we've seen during COVID and during the hurricanes. They were both common. Hospice services, certain administrative requirements were waived for home health and hospice. So certain documentation that you would need to have were waived. There's certain ambulance requirements, paperwork that is waived, certain pre-authorization that might be waived. As Maria mentioned, transportation is not generally a Medicare-covered service, but under certain situations, ambulance services will be covered. So we have, and what's important to note on this slide is that we have frequently asked questions, documentations for each of these, and they're listed on our website, and they are updated very often. You can see some of these were updated as recently as last week. So that is very important. Our website has updated information and very brief documents so that you don't have to read the entire 40-page waiver to find something that's applicable to you. Some of the other things that have been waived are providers normally can only operate in the state that they're licensed in, but for this emergency and for the hurricane emergencies, we were allowing doctors that were licensed in another state to go to the islands to provide services. So that was a very important waiver to make sure that providers could get to the patients that they needed. Long-term care facilities, end-stage renal disease. Lauren might speak more about this, but that was an important waiver where I recall trailers were being brought in because the facility itself was damaged. That's a very different situation than what you're seeing in COVID, where the facilities are fine, but the people can't be around each other, as opposed to the people can get there, but the facility is flooded. So depending on what the situation is, the waivers will be different. One very common waiver is regarding durable medical equipment, where normally you need an in-person visit to the doctor in order for him to prescribe a new wheelchair or any durable medical equipment, diabetes equipment. But during this time, we've been able to waive those types of requirements so that people can get their equipment without having to go in to the doctor or able to speak to the doctor on the phone. So there are several types of waivers that are available. They're all under the 1135. They're generally blanket waivers for the area affected for the time that they're affected. And they tend to be specific toward the situation that where flexibilities are needed. And there also exists the ability for providers to apply for different types of waivers that are specific to their needs, and they would contact the regional office for that. And I think that's about it. If there are any questions, we'll take them at the end, and we're very happy to respond to them. So I will pass it to the next presenter now. Thank you so much.
Good afternoon, everybody. My name is Lauren Reinertson, and I'm the Director of the Northeast Survey and Enforcement Division of CMS, and I'm very happy to speak with you today about preparing for hurricanes and other emergencies, and also in this COVID-19 environment. I will be speaking with you along with Roxanne Rocco of the Northeast Division, and she is a manager of the acute and the continuing care branch for our division, and knowledgeable about hospitals and continuing care facilities. So many of us here in CMS have stood with you in Puerto Rico and the Virgin Islands when you experienced hurricanes throughout the years. But recently, and it's true, it was in 2017, but it seems almost as if it was yesterday, those hurricanes of Irma and Maria were most memorable and most challenging. And we know exactly what you went through to provide care to Medicare beneficiaries under extremely challenging emergency situations, and the massive damage that came along to facilities, to your infrastructure of your islands, the electricity, the roads, the water supplies, the communications. I remember that we were talking with people who were calling from satellite phones from their roofs almost, and the transportation, the gasoline, the fuel disruptions, the difficulties getting necessary supplies and other ongoing challenges. That particular public health emergency extended for 9 months in Puerto Rico and a year in the Virgin Islands. And, here today, we are facing a public health emergency related to COVID-19, but you also are, and we all are aware, and we're facing it with some nervousness, I think, this possibility of a very strong hurricane season in Puerto Rico and the Virgin Islands this year again. And that coupled with COVID-19, there are some very serious concerns that we have that we want to make sure that you as providers and suppliers are ready. We want to make sure that you can get through this hurricane season as well as other emergencies. Next slide, please. So one of the most important things is that you need, as for all the 17 provider and supplier groups that participate in Medicare at CMS, you are required to have an emergency preparedness program, and that really should be your underpinning. And in 2016, there was a rule that came out, and it implemented this emergency preparedness program. And then in November of 2017, we started to enforce that rule. And in 2019, there was a slight revision of it that allowed some burden reduction to providers and suppliers. Now, the key about this emergency preparedness program that you're supposed to have is that the compliance is required at the condition level for Medicare participation. And that means that it is required, and that if you are non-compliant, it will affect or can affect your Medicare participation agreement, and it could put it in jeopardy. And specifically, there is some interpretive guidance and some survey procedures that you can be aware of if you so desire, and that's included in the CMS State Operations Manual Appendix Z. And that can give you a little bit more information about it. There are also websites available, and we do have individuals available to talk with you about it if you so need that additional information. But generally speaking, there are four major elements in an emergency preparedness program. One of the first elements is a risk assessment and a planning. And what that means is that when you develop your emergency plan, it has to be based on an assessment of the risks that you will be up against. And the concept behind it is an all hazards approach. And that is explained more in literature and various other things. But the point is that this plan is unique to your facility, and it is focusing on the capacity and the capabilities of your facility. If you're lucky enough to be part of a larger system, you might have additional supports for it, but generally speaking, it is focusing on the ability of your facility to cope with various emergencies. Now, this risk assessment and this plan, it needs regular evaluation. There are some rules about how frequently you have to do it, but the point is that you have to have a plan that's workable, that's current, and that can be implemented. And it has to be reevaluated periodically so that it is indeed current. The other element that is important is having policies and procedures, and those themselves have to be looked at on a regular basis. And they have to be based on your risk assessment and your plan. And very important things are, you have to have in the policies and procedures, you have to have evacuation plans. You have to have procedures for sheltering in place, tracking your patients and residents and staff during the emergency. We saw that, during Hurricane Maria, when the evacuation of the ESRD patients occurred in the U.S. Virgin Islands. So policies and procedures have to be regularly looked at and updated. And in addition to that, we'll go on to training in that. But the individuals who work for you have to be able to know about them and how to implement them, in an emergency situation. One of the key other elements is communication. And a communication plan is required, and you need to regularly evaluate that plan. You've got to have a plan that complies with both state and federal laws, and it's got to be able to coordinate patient care within the facility, across healthcare providers, and with state and local public health departments, and also emergency management systems. And as Marina said, that the facilities and the providers and suppliers who have put their time into developing a communication plan and an emergency plan that is well integrated really puts them in a much safer position should a major hurricane or disaster occur. And the fourth segment is training and testing. You need a testing program, you need a training program, you need initial training for your staff when they come in new, and they need to demonstrate the knowledge of the emergency procedures, because a hurricane can come in and cause issues in the middle of the night when you might not be there as an administrator, and everyone needs to know exactly what to do. And you also have to integrate that training and testing and conduct drills and exercises regularly to test to make sure that your emergency plan is workable. There also are some requirements for standby power systems, emergency power and that. And the key takeaway is that you need to evaluate and revise your emergency preparedness program regularly. And it's not just the weather emergencies of hurricanes. Puerto Rico, also has the earthquakes that you're dealing with periodically. But there are also other emergencies such as cyber attacks. And now we have this COVID-19 emergency situation on top of it, layering on top of a possible hurricane. And and one of the things that you need to know for your emergency planning is that you will need to have additional vigilance with infection control and evacuations and those types of actions that you might be forced to take in an emergency situation. Again, planning ahead, realizing what you need to do, and having the communication there with your local health and the federal government is absolutely critical. Next slide, please. So in addition to the general aspect of communication, we have to stress upon you all that timely communication is extremely important too. And that communication has to be had and made during the emergency itself when you are trying to respond to it, and also during the recovery period. And the reason why that's so important is because both the state agency in Puerto Rico and CMS New York and CMS, we need to know how you as providers and suppliers are doing in the challenge that you are facing in the hurricane or whatever emergency you have. We report out to CMS leadership on damaged facilities on a daily basis, challenges that you're facing with electrical systems and various other challenges that you have. And that is extremely important, that we know the status of the situations that you are as this emergency is unfolding. And we accelerate and we elevate those concerns quickly. And I know that we've done it in the hurricanes Irma and Maria, where there's communication not only to CMS in Puerto Rico with Marina and her staff, but also up to CMS New York also, and then we move that up to CMS leadership for action and integration within the other emergency departments that were available. So the real issue that I feel is the communication is extremely important. It's got to be timely. It's got to be as up to date as you can and quickly made. And please, reach out to us. We were available 24/7 during those types of emergencies, and we will continue to be responsive. Now, speaking of responding to emergencies, I'd like to turn it over to Rocky, who will mention some of the concerns or some of the ideas related to waivers and certification in CMS.
Thank you, Lauren. Okay, so just to elaborate further on Lauren's portion of the presentation, one responsibility of the Survey and Operations Group is ensuring that participating providers and suppliers, such as hospitals, nursing home, end-stage renal dialysis facilities, are in compliance with the Medicare participatory requirements. If they are not, they can be subject to enforcement action. However, to no fault of a facility, a natural disaster or public health emergency can impact a facility's ability to maintain compliance with the requirements. As a result, there may be some flexibility and assistance available, such as an individualized 1135 waiver, which you heard Denise talk about during her presentation. And to echo on Lauren's emphasis, if your facility is experiencing a hardship during a natural disaster or public health emergency, then it is imperative to contact your respective state agency and or your respective CMS office location to notify them of the hardship. They can provide you with assistance and determine what flexibilities to the Medicare requirements might be available to address and or remove barriers affecting care and services. Next slide, please. So again, as Denise mentioned during her presentation, the President must declare a national emergency or major disaster under the Stafford Act, which is also known as the Robert T. Stafford Disaster Relief Emergency Assistance Act of 1988, or the National Emergencies Act. And the Health and Human Services, HHS, Secretary also declares a public health emergency under Section 319 of the Public Health Services Act. Once declared, the Secretary under Section 1135 of the Social Security Act has the authority to temporarily waive certain Medicare, Medicaid, and Children's Health Insurance Program, otherwise known as CHIP, requirements. Next slide, please. So the purpose of the 1135 waiver is to address and mitigate regulatory barriers in order to ensure that there are sufficient healthcare items and services available to meet the needs of beneficiaries enrolled in Social Security Act programs located in the area where the natural disaster is occurring or the emergency is declared. It also enables providers and suppliers who are providing services in good faith to be reimbursed and exempt from enforcement sanctions. And that's absent any determinations of fraud or abuse. Next slide, please. So to tell you a little bit as to what 1135 waivers do and don't do. They don't waive state licensure requirements. They only apply to federal rules and regulations. They are not a grant or financial assistance program, nor do they allow for reimbursement for services that routinely are not covered. In addition, 1135 waivers are time limited, and they usually end after the disaster national emergency is declared over or 60 days from issuance of the waiver. However, what waivers do allow, they do afford flexibility to specific regulatory and or participatory requirements without a healthcare provider or supplier being sanctioned for noncompliance with the requirements. The impacted participating provider or supplier must submit a request to CMS for an 1135 waiver indicating what regulations or participatory requirements that they are in need of a waiver to because they are unable to remain in compliance with those regulations due to the declared major disaster or public health emergency. Some examples of 1135 waivers. So in light of the PHE with COVID-19, underneath President Trump's administration, a blanket waiver was issued for special purpose renal dialysis facilities, otherwise known as SPRDF. That allowed these temporary, it's a temporary end-stage renal dialysis facility to open without having to have a federal initial certification survey first prior to operation. This facilitated an increase to access to care for those patients in need of dialysis, as well as it helped cohort patients who tested positive for COVID-19 infection. Some examples of other waivers included underneath the Emergency Medical and Treatment Labor Act, EMTALA, individuals presenting to a hospital's emergency department must receive a medical screening examination, known as the MSE, at the hospital's emergency department, and they cannot be redirected to go elsewhere for the MSE. However, underneath a blanket waiver, that requirement may be waived, allowing hospitals to safely redirect patients to an alternate care site to receive a medical screening exam to rule out emergency medical condition. We have seen this in light of COVID with trying to mitigate the risk of transmission of infection. Another requirement was also for nursing homes. One of the requirements relies on physicians have to perform in-person assessments. Underneath this PHE, the President's administration issued a blanket waiver that waived the in-person physician assessment and actually allowed utilizing telehealth methods, such as through the use of video technology. Another waiver is hospice and home health agencies require that a supervisor perform an annual on-site monitoring visit of nurse aides rendering healthcare services. Under declared emergencies, such as the current PHE, these visits may be postponed without the hospice center or home health agency being penalized for not meeting the annual requirement. In addition, to echo what Denise said during her presentation, in addition to an individualized 1135 waiver, the President's administration may initiate what's called a blanket waiver. A blanket waiver covers all the provider or supplier types in a specific geographical area where the President has declared an emergency for the specific regulation that is being waived. As a result, that provider or supplier does not need to apply for an individual 1135 waiver for the regulation that is covered underneath the blanket waiver. For example, the President declares a major disaster in USVI because of a hurricane. A blanket waiver is issued waiving the MSE location requirements for hospitals under EMTALA, as described in my first example. The blanket waiver applies to all hospitals in that location in which the emergency is declared. Therefore, each hospital in that location does not need to apply for a specific 1135 waiver, as they are covered underneath the blanket waiver. Next slide, please. So for any questions regarding 1135 waivers, please send all inquiries for states and U.S. territories in the Northeast Division that are covered by CMS Boston, CMS New York, and CMS Philadelphia to the Philadelphia Division of Survey and Certification email box, which is listed on that slide. Again, should your facility be experiencing a hardship due to a declared disaster or public health emergency, please contact your respective state agency and or your respective CMS location so we can provide you with assistance to enable you to continue to meet the health care needs of the beneficiaries in your respective locations. Next slide, please. If you have any additional questions or need assistance, you can contact me, or you may contact Captain Maury Meredith or Lauren Reinertsen. And that concludes my portion of the presentation.
Okay, thank you, Rocky. Good afternoon, everybody. My name is Evelise Salsing, a health insurance analyst working at CMS in the divisions of Medicare and CHIP as the lead for Puerto Rico, the state lead for Puerto Rico and the USVI. My presentation today will be focused on Medicare and CHIP flexibilities and authorities available during an emergency. Next slide, please. I would like to point out that Medicaid and CHIP plays a critical role in helping states and territories respond to major public health crises and natural disaster. Next slide. States and territories may waive certain Medicaid and CHIP requirements using different authorities. State, territory, state plan flexibility. General state plan flexibility. State Medicaid and CHIP programs have the ability to reduce and eliminate barriers for screening and treatment during periods of emergency or disaster under a national or state emergency, including temporary changes to Medicaid to simplify enrollment and renewal processes, expanding presenting eligibility to new providers and new population, making the Medicaid agency a qualified entity for presumptive eligibility determinations, and ability to submit a state plan amendment to make adjustments to cost shadings for impacted individuals. The use of these flexibilities may cover the entire state Medicaid population or specific to those impacted during impacted populations under a state plan authority. For example, on April and May of 2020, Puerto Rico and the USVI took advantage of some of this flexibility, announcing that it will ensure coverage for testing and treatment of COVID-19, remove related prior authorization requirements, and require providers to treat individuals regardless of ability to pay any associated co-payments. CHIP disaster relief staff. States with separate CHIP programs may submit a disaster relief state plan amendment that can be retroactive and allows for flexibility similar to those available in Medicaid, such as waivers or cost shading and premiums, and extending the time frame for renewals. PR in the USVI do not have a separate CHIP, so they submit those requests through the regular state plan amendments. The verification plan, state or territories can modify their Medicaid CHIP verification processes in response to a disaster by documenting those changes in their verification plan. These provisions will go into effect immediately. The state submit an updated verification plan and no CMS approval is required. The 1915C waiver Appendix K, waivers operating under 19C authority providing home and community-based services may be modified with the submission of an appendix case during an emergency. CMS can approve this appendix retroactively, permitting a state to establish an emergency hotline, provide case management and applicable personal care to be conducted telephonically or via other telehealth meetings, increase the number of individuals covered under the waivers, modify providers' requirements to increase access, and pay for ACDS services during short-term hospital or institutional stay. A state may also increase individual eligibility cost limits, modify services and limitations, and permit payments to family caregivers on the appendix case. This appendix case may also be used to address qualifying population that may be in quarantine due to COVID-19. Now I'm going to talk about the Medicare and CHIP waivers. Section 1902E14 of the Social Security Act authorized the Secretary to waive certain provisions to the Medicare or CHIP statutes to ensure that states are able to establish income and eligibility determination systems that protect beneficiaries. These provisions will go into effect as of the day approved by CMS. retroactive implementation is allowable. The Emergency Section 1115 waivers. Emergency Section 1115 waivers process allows for an expedited submission and approval timeline without requiring either a state or federal public comment period while there is a disaster, public health emergency, or other sudden emergency that could have been reasonably foreseen. These waivers were deployed to ensure coverage following September 11 for individuals impacted by Hurricane Katrina and to extend coverage to those impacted by the Flint water crisis. Emergency Section 1115 demonstration has been used to extend coverage to target populations, simplify application processes, and grant temporary coverage based on member self-attestation without requiring documentation. In addition to simplify application and expedite enrollment, Emergency Section 1115 demonstration permit extensions or limited or full benefits to target population, which may include individuals with income or resources beyond the existing state plan limits. The full spectrum of 1115 authority is available under the emergency options, which could include flexibility authorization related to delivery system reimbursement, applications and enrollment, as well as expanding eligibility. Section 1135 waivers flexibility. Under Section 1135 waiver flexibility, the Secretary has the authority to temporarily waive or modify certain Medicare, Medicaid, and CHIP requirements to ensure that sufficient health care items and services are available to meet the needs of enrollees in an emergency area. The Secretary may invoke 1135 waiver authority when a declaration of emergency or disaster under the National Emergency Act or Stafford Act and a Public Health Emergency Declaration under Section 319 of the Public Health Services Act has been declared. The authority enables providers to furnish needed items and services in good faith during times of disaster and be reimbursed and exempted from sanctions. As Denise says in her presentations, 1135 waivers typically end no later than the termination of the emergency period or 60 days from the day the waiver or modification is published. Today, CMS has announced a number of waivers under 1135 authority, such as expansions of telehealth coverage. Starting March 6, 2020, and for the durations of the emergency, CMS will reimburse for office, hospital, and other visits furnished via telehealth in all areas of the country and in all settings, including in a patient's place of residence. In April and in May, Puerto Rico and the USPI received approvals for the Section 1135 waiver in response to COVID-19 national emergency. They also received approvals for the Section 1135 for Hurricanes Irma and Maria in 2017. Some of those flexibilities approved on the waivers are waiving prior authorization requirements to remove barriers to needed services, streamlining providers' enrollment processes to ensure access to care for beneficiaries, allowing care to be provided in alternative settings in the event a facility is evacuated to an unlicensed facility, suspending certain nursing home screening requirements to provide administrative relief, and extending deadlines for appeal and state fair hearing requests. States and territories seeking relief for Medicaid and CHIP requirements are encouraged to submit a Section 1135 waiver request to CMS for review and approval ahead of the emergency or during the emergency. Next slide, please. This slide, no, the one, thank you. This slide shows samples of other flexibilities that do not require an amendment to an estate plan or verification plan. The 42 CFR 435.912 provides an extension to timeline standards for application and renewals in an emergency or under unusual circumstances. For instance, it allowed the Medicaid agency to expand eligibility for those who are due for recertification during the emergency time. The other authorities, the 42 CFR 435.952C, allow the state or territories to accept self-attestations when documentation is not available due to a disaster. Next slide. Okay, and this page provides federal resources that are helpful during emergency and disaster. These links will take you to the Medicare and CHIP Disaster Preparedness Toolkit created by CMS to provide state and territories with additional disaster-related information. The Disaster Toolkit is a long-standing resource that has been available to state and territories on CMS website, Medicaid.gov. It outlines numbers or strategies available to support Medicaid and CHIP operations and enrollees in time of crisis. State and territories are encouraged to be familiarized with this resource as part of the emergency preparedness planning. Many of these flexibility described in the toolkit help Puerto Rico and the USVI in the response to Hurricane Maria and Irma in 2017, and it's helping state and territories in their response to COVID-19 pandemic. As you know, when a disaster strikes, state and territories should contact their CMS regional office as soon as possible to discuss anticipated changes to waiver operations or needed authority. CMS will work with the state and territory to determine what changes may be needed while also providing key considerations such as effective date and impacts to other programs. That's all I have for today. Thank you so much.
Thank you, Ivelisse. This is Thomas Bain from the Centers for Medicare and Medicaid Services, and we'll now transition into the Q&A portion. So there is a chat box. This is type questions here for speakers. So if you'd like to ask a question, please put it in the box and we will get to it. But thank you to Marina, Denise, Lauren, Rocky, and Ivelisse for sharing this really valuable information. And thank you to FEMA for partnering with HHS on this webinar series. One of the things that we hope is that this information is helpful to you in advance of any potential hurricanes during this hurricane season. I'll start with a question for Marina. Marina, as there's many partners on the phone or on the webinar from the U.S. Virgin Islands as well as Puerto Rico, what's the way for them to stay connected to CMS Puerto Rico field office?
The best way is either to call us or to write to us. I could provide our email. It's marina.diaz@cms.hhs.gov. And our phone number is 787-285-1005.
Thank you, Marina. And that information is in the slides as well, I believe, and everyone will be able to download the slides from this webinar. And so I think I'll just, as we have a couple of minutes for people to type in their questions, I know a lot of information and resources were shared, but maybe just to underscore, if you were to direct people to one website or one resource or one way to stay connected to your part of CMS, what would be your recommendation? And so we've had Marina go. Denise, how about you? Is there one website or way to contact the regional office that you would recommend for people that are on the webinar to stay connected and with the most updated information?
The CMS website has the most updated information and has what the emergency is. So it'll say on the CMS website, for more COVID information, and you click on that, and there are all these frequently asked questions for COVID. So really, and one of the things that my staff does is we just Google the answer to the question, because it's changing so rapidly sometimes that policy that was last week, like telehealth policy, it has to be video and voice, will change. And so every time we would get a question, we would try to get the latest information, and you can see on the website it is updated regularly and has a date of when it was last updated. So really, our CMS website is definitely the best, the easiest, one-stop shopping. Any question you have, you type it right in, and the answers, the most current answers will come up. So that is really the best place to go. If you need information, if you want to send information specifically to our region, let me tell you what our Region 2 website our email address is. One sec, I'm finding it because it's long and it is it's weird acronyms. So hang on one second. It is got a lot of acronyms. Hang on just one sec. You go ahead and ask the question, somebody else, and I will get the contact information for you for our corporate mailbox.
Great, thank you, Denise. And there is a chat box up there, and Raul has put in some of the websites and telephone numbers so far, so we can put it in the chat box as well when you get that. And we did get a question in the question box if the presentation can be emailed to us. I know that it can be downloaded from the webinar, but if you email any of the email addresses like the PRFO one, we will respond with a copy of the PowerPoint. I'll turn now to Lauren and Rocky. Is there just one resource or maybe a couple resources that you wanted to underscore for people who are on the line?
This is Lauren. I think if you have a specific question or even a general question, going to that ROPHI DSC email box that we had in there, I think we would get you the answers as quickly as possible with that. And then for the emergency preparedness program, the link was in the slides. Rocky, do you want to say anything about the waivers at all?
If you have any specific questions regarding waivers, you're more than welcome to email me or submit your question through to the Philadelphia mailbox. In addition, the CMS website does have some additional information regarding 1135 waivers.
Excellent. Thank you both. And Evelise, same question in terms of waivers or flexibilities in relation to Medicaid and CHIP and disasters. Is there any resource that you want to underscore for everyone?
Hi, this is Evelise. No, I'm going to say exactly what our colleague said before. The best way to get a response related to any federal resources available is by visiting the Medicaid.gov and, getting into those links that are on the presentations. If they had any related questions specific to Medicaid or CHIP, they can, send me an email or reach out to me directly, and I will be more than happy to respond. I can send you that information so you can share with them.
Thank you, Evelise. And it looks like Denise found the corporate mailbox for the New York office for the fee-for-service side of Medicare, so feel free to copy and paste that if you need that as a resource. It doesn't look like there are any additional... Hi,
it's Denise again. Just before we go on, it's OPOLE_IFM_NY. So you can't see it because the whole thing is underlined, but those are not spaces, they're underscored, which wasn't a good idea when I look at it now, but that is the our office's email address. If you just copy and paste, it'd probably be better.
Thank you, Denise. That's good to highlight for people. Okay, I don't see any additional questions coming in. So Marina, I'll turn it back to you for any concluding remarks that you'd like to make.
Only to thank everybody, especially FEMA, and an honor to join this effort with my colleagues in New York. And, you know, I'm just an email away or a phone call away. Thank you.
And also, it's Denise again, anybody that you contact will get your question to the right person. So if you send Marina something that should go to me, she will send it to me. If I get something and it should go to Lauren, I will send it to Lauren. We have really great communication among our divisions, and we will definitely, if I'm not the right person, we'll get it to the person that is the right person, and we'll get your response. So go ahead, and if you're not sure if you're sending it to the right person, don't worry about it. We will take care of it.
Thank you, Denise. Jose, should we turn it back to you? I think that concludes our webinar today. Anything else?
Yeah, I think we're good. Thank you guys for joining us in this collaborative effort with FEMA and HHS and for working with us on to better prepare our region. New York, New Jersey, USVI, and Puerto Rico. For the audience, remember that preparedness starts with us. So if we work towards a better preparedness and readiness posture, we can help out or mitigate the consequences of whatever the threats we are subject to. So everybody, thank you for joining us today, and we hope to see you on our next webinars. Which is next week. I believe it's on Monday and Tuesday, and we'll be sending out these
Thursday and Friday because of the holiday. Sorry, Jose.
Oh yeah, we'll be sending out this through the bulletin, so make sure to look at your emails if you register for the distribution. We'll have a couple of webinars upcoming, so stay tuned, and thank you everybody for joining us today.